House Oversight Subcommittee on Public Health and Food Security will come to order. Would the clerk please take the attendance?
Chair Beerline.
Here.
Representatives Paquette. I'm here. Green. McDonald.
Here.
Cerniglu.
Here.
Mr. Chair, you have a quorum.
Thank you. Representative Paquette moves to approve the minutes of the June 24th meeting. Hearing no objection, they are approved. Today we're going to continue the discussion on the psychiatric bed shortage in Michigan. We have a lot of people who would like to have a moment before the committee today, and so I would ask everyone to keep your remarks as pertinent as possible, and we'll try to move through this as quickly as we can to get everybody in. With this committee butting up to the 1:30 session start time, we have to stop at 1:30. So first, we are joined by Marianne Huff, the President and CEO of the Mental Health Association of Michigan. So Ms. Huff, if you are the leading statewide voice on behavioral health policy and advocacy with decades of experience, and we look forward to hearing what you have to say. If you just push the red button and get started.
I will. Thank you very much. First of all, I want to say thank you for giving me the opportunity to be here today. I am Marianne Huff with the Mental Health Association in Michigan, and we are the state's oldest advocacy organization concerned with adults, youth, and children of all ages who experience mental health conditions and addictions. I am the president and CEO of the organization, but by way of history, I'm also a licensed clinical social worker. And what brought me to the work is having a lot of family members with serious mental health issues, including a grandmother and an uncle, both of whom had schizophrenia, who were in state hospitals, and other family members. We do a lot of advocacy at MHAM, and one of the things that I wanted to focus on today for this committee is the necessity of having increased psychiatric beds, particularly in the state hospital, for children and adolescents with serious emotional disturbances. One of the things that I also wanted this committee to take away is that in my role at MHAM, I get a lot of calls from families who have children who have behaviors that are rather extreme. And a lot of times these families really struggle with having access to mental health treatment that's appropriate to the level of care needs of the child or the adolescent. And that's one of the main things that I wanted to talk about today. You know, years ago, 30 years ago, we had two state psychiatric hospitals for children. One was Hawthorne Center, which of course is being rebuilt on its campus over there in Northville on Haggerty Road. But we also had Fairlawn Center, which was located in Pontiac. And also in the 90s, we also had what was called specialized residential. So if a child found themselves in Hawthorne Center or Fairlawn Center, they would be able to step down through the level of care to specialized residential and then to home. The problem we have in 2025, so 30 plus years later, is we don't have the same robust level of care that we had back in the early 90s. As a matter of fact, one of the only ways that a child with serious emotional disturbance can access specialized residential treatment is if they encounter the juvenile justice system. That's what's changed. One of the policy problems that has arisen in the last 20 years is that, and again, I want to make sure I say this judiciously, restraint and seclusion rules were changed at the state level so that child caring institutions they're really not allowed to intervene with behavior with children and adolescents when they're really out of control. That's problematic. Again, not advocating for kids to be in restraints or in seclusion, but when you have children with extreme behaviors, you have to have ways to manage those behaviors. When the law was changed in the early 2000s, it meant that community mental health could no longer use its Medicaid in these specialized residential programs. And so it's very important that all of you understand that, because, for example, a place that I'm very familiar with personally is Children's Home of Detroit, which was located in Grosse Pointe. It was around for 100 years, and when these rules changed, it had to close. So that meant that if a child had extreme behaviors, and this is what we're dealing with now, they have two options. They can go to the community hospital, and I want to make a clear distinction between a community inpatient psychiatric unit or a psychiatric hospital and a state psychiatric hospital. State psychiatric hospitals, I'm sure you're aware, are for those individuals who have more significant behavioral health issues and problematic behaviors and challenges. So I want to make sure that I really talk about that. What might be helpful is for me to kind of give you a story based on my experience as an advocate of families that I've worked with whose children have found themselves in both the state hospital, not long enough, if they could get in the state hospital, the juvenile justice system so they could get residential treatment, and then trying to get outpatient services from the community mental health system. And one more policy item that I want to make sure that I put forth to all of you, I'm not sure if you've heard this or not, but when we no longer had the option of specialized residential, one thing the state of Michigan did do is we pursued a specific type of waiver called a SED waiver, which is for children with serious emotional disturbance. We also had what was called the 1915B3 waiver. That's a Medicaid waiver that allows states to do creative things with their money. We don't have that waiver, but we do have services that were intended to be used in the community to keep kids out of institutions. So we still have that. But what I want to make sure I mention is that while that's great, sometimes those services are not robust enough, nor are they appropriate for kids who are having extreme behaviors. You know, one of the things that can happen is, so let me just kind of give you a story. So I get a call from a mom who has a child with significant acting out behaviors. And a lot of times these kids are already connected with the local community mental health, but because the community mental health struggles with its funding, the types of services that these kids and adolescents need to keep them in the community, if you will, you might have heard people talk about what's called community living supports or respite services. Those types of services, those services are really designed to help keep kids out of institutions. One of the problems that we've had, and this was one of the major factors behind the lawsuit against the state, you might be aware of, it was called KB versus Lyon, was that CMHs were not able to provide the full array of services for a variety of reasons, including funding issues, so that these kids could stay out of institutions, and institutions that actually don't exist anymore. So I get a call from this mom, and her child is getting services through a particular CMH, but the child is continually acting out, threatening to harm themselves, other people, ends up in the emergency room. So then mom says to me, I've been in the, and this a lot of time, these communications are through email. I've been in the emergency room for 3 weeks with my daughter. Can't get her into a program. And by the way, I'm a single parent and I own my own business. I'm not able to work. This is an individual that really needs to be in the state hospital and then needs to be able to transition down to residential care, which we don't have. So that's one scenario, that's one pathway. The other pathway is mom or dad call, 911 because the child is engaging in extreme behaviors. And when I say extreme behaviors, I mean I've heard everything from beating parents over the head, throwing furniture out the bedroom window so that it lands on top of the parent's car, threatening siblings, trying to choke people. I mean, we're talking extreme behaviors, and the thing I want to say too, because some people have said to me, well, aren't these just bad kids? And I'm like, no, they're not bad kids. These are kids who have mental health conditions that show up differently because they're kids in adolescence. Like, for example, depression in a child or an adolescent does not look like depression in an adult. It often comes with acting out behavior. So the other option, and this did not happen in this particular case, so I'm going to switch to another situation where I get a call from a family who says, I called 911 because that's what the therapist said, child acts out, call 911. Well, now my son or daughter now has a domestic violence charge, is on their way to the juvenile detention center. And this sounds like, and again, it's hard for me to tell the chronicity of the patterns with some of these situations unless I get really involved in them. But you see, those are the only two pathways in Michigan. And if you take anything away from what I'm saying today, it's that we really need to broaden and strengthen the continuum of care. Kids should not have to go into the juvenile justice system to get residential treatment, which is typically out of state, because right now in Michigan, we don't have a good way to license specialized psychiatric residential treatment programs, especially on the commercial payer side. So what I want you to be aware of is that, like Blue Cross Blue Shield will pay for psychiatric residential treatment for these children with serious emotional disturbance, but because we don't have a way to license those programs in Michigan, a lot of times these kids are sent out of state. That happens on the juvenile justice side of the equation. I'm aware of an individual whose child was sent to Wyoming for a year and a half. Makes it difficult for the family to be involved. The other thing we need to look at is making sure that there's enough funding so that we can keep kids out of institutions. The SED waiver that I referenced earlier is a specialized Medicaid waiver which waives the income requirements of families, because what typically happens is if a family, if the parents have good jobs, well, they're not necessarily going to qualify. Their child may be chronic enough or have a condition that's serious enough that warrants community mental health treatment. But if they don't qualify for traditional Medicaid, and they're not going to, then those services have to be paid for out of state general fund, which that was cut, in 2014 by 65%. So we have to take a look at that issue. We have to look at what do we do with these kids who have these significant conditions, but what do we also do to keep these kids out of these situations? We also have in Michigan what's called psychiatric residential treatment facilities, or PRTFs. We have 2 that are operational right now, one through Hope Networks, one through Pine Rest. I get calls from families a lot. Ms. Huff, can you talk to the state of Michigan about getting my son or daughter into a psychiatric residential treatment facility? Well, they're at max right now. There's waiting lists for these programs. The other thing before I close that I want to add is we also need crisis residential and we need crisis respite. We need crisis residential for those times where maybe going to the emergency room isn't appropriate, but maybe staying at home isn't appropriate. We need crisis respite for families. Unless you've experienced or had to navigate behaviors with a child with serious emotional disturbance, it can be really hard to imagine how emotionally and physically and psychologically difficult and draining that can be for parents. But I think we need to be looking at, the full continuum is not just emergency room or state hospital or outpatient. It's what can we do to mitigate the behavior and the symptoms so that people don't need to end up in longer term placements, because I think that's something that's definitely possible. So that concludes my testimony. I don't know if you have questions for me, but I'm happy to answer those to the best of my ability.
Thank you. I'm gonna ask the first one, and then we do have some other questions. So as you've navigated this and as you've been doing this throughout your career, who seems to be hit the hardest from the state's disinvestment from these programs? Is it kids? Is it families? Is it the caregiver? Is it the provider? Who seems to be bearing the most burden?
I think the families and the children who grow up, the children who grow up to be lifetime participants in the public mental health system when I don't think they have to. I know of a situation of a young person, well, they're not young now, who was in the state hospital in the 1990s, who, if you met this person now, a very, very successful person because of early intervention, hasn't been in the public mental health system since 1995, is not on SSI or Social Security disability, went on from that to become very successful. The point is, we lack in prevention, and we lack in supporting families when they have these kids with these significant behaviors. A lot of times, and I don't know that it's necessarily intentional, but parents get blamed, particularly moms get blamed a lot when their children have mental health issues. And, we now know that there is a huge genetic component to these disorders. I referenced earlier my own family. My grandmother and my uncle both had schizophrenia. I had a brother who passed away in 2008 who had bipolar disorder. I don't want to go on and on with the family members, but there's clearly a genetic component to these conditions. So, Representative, to answer your question, I think the individuals who need the treatment themselves probably bear the most cost. But if you want to look at it from a fiscal point of view, better to put the money up front in providing care to these children when they're younger, when the brain is still, we know about neuroplasticity. The brain is plastic. These children have a much better opportunity to learn different ways of being, to outgrow these behaviors. And then they don't have to cost society money by being in community mental health for their entire lives. Providers, we have some really good providers, but this is not easy work. So it's not easy to find people that are willing to do this type of work.
Thank you for that. Representative Green.
Thank you so much. This hits on I have so many questions and so many comments on this, because situation, family of 4, income of probably maybe $90,000. Young boy, various medical conditions from autism to Klinefelter syndrome, but chased mom with a knife, put holes in the wall. But there are the families that have that gap that they aren't covered by any of community mental health. They have to pay privately if their insurance even covers anything at all. So the family did find an ABA. It was modified because there's no consistency with it. It's very bizarre. So it was kind of how it met the family's needs, but they paid for that all out of their pocket. Boy now graduating, still on the learning spectrum, 0 behavioral issues at all. But so went from chasing mom and dad with a knife, but due to intensive therapy for 4 years in home, had to be pulled out of school though, will be a productive member of society, not on SSI, not on any of. So I completely agree with you on, and I'm sorry I get a little emotional because it's a real thing with my friends, with my family. So you touched on continuum of care. And I guess how do I would even phrase, it is my understanding that there's a new RFP with the department for continuum of care. Do you know what I'm not as familiar in this world.
I'm not sure about that. I know that the department has been trying to expand the continuum of care. But Rep. Green, you hit on an interesting issue. So one of the concerns that I've had for a long time is that the services through public mental health should not be based upon who the payer is. And what I mean by that is, you know, in 2014, and I know this because I'm a former CMH director, the general fund was cut by 65%. And general fund for CMH is what pays for families like the one you're talking about, where they have an income of $90,000, where they're not going to qualify for Medicaid. Now, there's an ability to pay portion with general fund, but to my knowledge, traditional payers like Blue Cross, Priority Health, others, they're not going to pay for things like community living supports and respite and things that could have helped this family further in addition to the ABA. Now, ABA, of course, is paid for through traditional private payers. We need to take a look at that too, because to me it seems really, it's frustrating to me that if you're in a certain income bracket, if you're frankly, if you're poor enough, you can get these services, but, you know, if you aren't, and they can be very expensive services to pay for privately.
Oh, this devastated the family. They used every
Exactly.
single penny to pay for this.
Then you
treatment.
can't get them, right? And so that's another policy issue that I think really needs to be looked at. But my analogy will always be this, when you think of it. On the physical health side, if an older person breaks a hip, they get the hip surgery, they transition down through levels of care, they go maybe to a rehab facility, then if they can, they go home, maybe they continue to get rehab in the home. Mental health still has a lot of, I know it's 2025, we still have a lot of stigma around mental health, unfortunately. It is not looked upon, I think, equitably as if it was physical health, and yet we're talking about the brain. We don't think about mental health transition the same way. You know, one of the things that I get calls about too is people will go into a psychiatric hospital, the family will go through the whole process of civilly committing somebody. They're in the hospital for 3 or 4 days, they're not even stable, they're sent home. Mm-hmm. You know, so it becomes this, it's very much a vicious cycle that we have. I hope I answered your question.
Sort of, but thank you for sharing.
I'm sorry I don't know about the RFP,
yeah, that's
but
okay.
now I got to go look it up, so thank you.
As we transition kids to other states for treatment, whether it's mental health treatment or they wind up in the juvenile justice system, and we've eliminated a lot of those facilities within the state as well, it seems to be, we know that this is an expensive, to fix this is not free. No. Right? But we're spending that money. Mm-hmm. We're just spending it in other states without family supports. Does that make a lot of sense to you?
Absolutely not, because one of the keys to a child or an adolescent getting better is family involvement. And how can a family be involved with their child if they're in like this family I was sharing, Wyoming or Utah or Georgia? Like, how do you do that? That means paying for what, airfare to go down there and back, hotel rooms, and you can't do that very frequently. And let's face it, I mean, I think technology is wonderful, but having a Zoom call with your child who's in a residential program is not the same as, you know, having them with you. The other thing is, what residential programs will do and the state hospital has done is when a child's ready to come home, they have leaves of absence where they come home on the weekends to try it out. You don't get the opportunity to try it out and see how it's going to go, because if a child's been gone for a minute, when they come home, talk about an adjustment for the child and the family. So you have no opportunity to even observe, how's this child doing when they come back into the family home? Are there issues in the family that need to be addressed?
Thank you. Representative McDonald.
I can't see you and be on the mic at the same time. Hi. Thank you so much for your testimony today. I'm listening to you and I'm thinking, what can we do? What can we do? And then, obviously, to fix these things would cost money. And then I think what we're looking at today is going to be absolutely luxurious if the Medicaid cuts come. What, how can you tell us the effects of that on our mental health care system?
Well, I've thought a lot about that. And something that I think we should all be thinking about, I know at MHAM we have been, and the other advocacy organizations like the ARC Michigan and Disability Rights Michigan, is Michigan prided itself for a long time on reducing the number of institutions, and we should be proud of that. I think we, on the mental health side, we kind of went a little bit too far. But what we should feel good about is because of those Medicaid waivers, we were able to put a lot of people that would have been in institutions, people with intellectual, developmental disabilities, significant autism, they are able to be successfully in the community. They are able to be successfully in the community because of Medicaid. Because anybody who has an intellectual or developmental disability or autism, their services are about 99% Medicaid funded. And one of the things that does keep me up at night is we're looking at what's going on above our heads right now, if those cuts are realized, is how ill-prepared the state of Michigan is to navigate that. Because if we think we have a problem now, where are all these people who have paid staff in their homes, getting community living supports, home help, all these services to live in the community, where are they going to go when we have no more institutions for them to go to? That's what I think we should all be thinking about, is what's going to happen to these most vulnerable people.
And it also really affects special education in our public schools, where they have taken over so much of the load of what families need and the treatment kids are getting. And a lot of that, just a few years ago, I'm not sure how many, maybe 3 years ago, we just made it possible for Medicaid and private insurance to be used in the schools to pay for services. And that's not going to be helpful to schools that are already overburdened with these issues and how to pay for them.
Yep, it's well, from where I'm sitting, it's a pretty scary time when I think about our most vulnerable people.
I just have one final question. In your role as the chair and president of the association, so you kind of see the overarching position that Michigan is in. It's not just from a private hospital side or the state hospital side. The continuous message kind of seems to be, from all of the testimony received over the last month, that there is a lack, especially in child and adolescent beds, and that they are the most severe beds. It's not necessarily the private pay local hospital beds. It's the severe state hospital facility beds that just don't exist anymore.
Yep.
How many beds do you think we are short from a state level in the state of Michigan?
Well,
And I'm not holding you to a number. Just if you had to, round it, that's fine.
well, when I think about the calls I get and the families that I'm aware of, I would say we need, I'm going to qualify my answer 2 different ways. This is based on not having specialized residential easily accessible. If we had specialized residential easily accessible, you probably wouldn't need as many psychiatric beds as I'm going to say. I would say at least 50 to 100. That might even be too low. But that's what I'm thinking. Especially if we want to provide quality care and stop the vicious cycle of kids ending up in emergency rooms where they stay for a long time, and then a lot of times they don't even get a bed.
Yeah, it's close to the number of beds they cut from the Caro facility when they rebuilt it. So thank you for that. I
Well,
appreciate
thank
it.
you.
Thank you for your testimony today.
Thank you very much.
Next, I would like to welcome Stephen Burnham, who is the retired Kalamazoo County Probate Registrar. And we're going to welcome back Chris Pinter, who will be joining him. Chris is the Executive Director of Bay Aranet Community Mental Health. We had to cut him short last time he was here. So thank you both, and you can begin whenever you're ready.
Opportunity today. Ms. Huff and I talked a little bit before and I accused her of stealing my speech, hacking my computer, because a lot of this stuff. I grew up in Kansas in a Bible church, and I'm sorry if I audibly said any amens, you go sisters, while she was. A lot of what she was saying, it's like, that's exactly it. You know, I'm surprised we all didn't just stand up. It's a lot, but, so.
Do you have your mic on?
There, is it on? Okay. I'm used to talking loud, so sorry. Do you want me to repeat all of that, or? Okay, good, because I can't. So I prepared 4 pages of remarks, but before I start, I want to supplement a couple of the questions that I had, because y'all had some really good questions about the testimony and where we stand. So you mentioned I'm retired from Kalamazoo County after 30 years. So a little bit about that. I started as assistant corporation counsel in 1991. So I worked with the county. When I started with Kalamazoo County, community mental health was right next to our buildings and grounds, our parks department, finance department, HR department. It was a county department. In fact, Kalamazoo had, and I was the staff attorney for our board, we had the last joint human service CMH board that sunsetted, but the state let us keep going. We evolved from that into when the state started looking in the mid-90s into this authority status, which is what all these CMHs are now. But I think fundamentally, a lot of folks don't even know where the CMH system comes from. I cannot tell you how often I am asked, well, are you a 501c3? What are you? No, we are a governmental entity formed by the counties that created us. And I think if we can't follow that breadcrumbs back, we're missing some of the answers to some of these questions that are going on. I was asked to come over and I was the corporate counsel and HR director when we set up our CMH back in 94, 95. I served in that role. We became an authority in 97 when all that happened, and then it's evolved from there. I left there and went over to become the probate register. I was also the court administrator, and I was an attorney referee. I say this, I retired after 30 years. My wife said I couldn't keep a job, but it was all with the same employer. I just had a lot of different jobs within that employment. But how this all fits together is, as an attorney referee, I did delinquency cases, DL cases. I did abuse and neglect cases. Again, parroting along with what Ms. Huff shared, I cannot tell you how many times when I would do my prelims, and I had the Monday prelims, so I got all the kids that were picked up over the weekend, and they would come in front of me, and from my CMH experience, I'm sitting there going, why is this 12-year-old, why is this 15-year-old involved in the juvenile justice system? Why are we not getting community mental health involved? So that's part of that. The other part I just wanted to say as far as some of the money. When I started with CMH, and I think this is something to keep in mind with the cuts that are being talked right now and where the system is, we were 65% general fund, 35% Medicaid. And I don't think I can emphasize that enough as far as what that means. So think about Medicaid as like your Blue Cross plan. Something happens, you have to fit the right code to be able to do it. And that's how we functioned as a CMH back then. We had all this money, if you will, of general fund. So if somebody comes in, an example comes in like Ms. Huff said, his family, or that you did, Representative Green, we have this family and we're like, you know what, we're gonna get creative. We have general fund. General fund is like our own personal checkbook. As long as we're doing what's required by the code, the Michigan Mental Health Code, we could put together in fashion, fit in all the rules and do this. And we could try something else. Say, you know what, let's try it for 6 months. And then we're gonna come back, see if that becomes the best practice. Are we helping the family? Are we helping the kid? Fast forward to today, and I'm sure you already know this, so I'm sorry if I'm repeating, but the CMH system is probably 95% funded by Medicaid, if not higher, and this. So think about what we've become. You've taken the CMH system that's supposed to serve the SED, the most severely emotionally disturbed kids, the severe and persistent mentally ill, and the IDD, developmentally disabled. We're supposed to be that stopgap at the bottom. And when we had all this general fund, we could get creative on it. Well, we can't with this because we basically become, a pharmacy benefit manager, or you're just, if it won't fit a code, you can't. And then you start feeding into that, and then that's part of the secular argument as far as, yes, there's a lot more money in the mental health system, but you probably heard testimony, and I reviewed all the testimony that had been given to this committee. They're always turning back over Medicaid. Well, if you can't find a code for it, you can't spend it. And I think the question that's not asked is, but is there a need? And I think we've already heard today, and you all have heard through all your testimony, there's a huge need for this. So I'm retired, and I suck at retirement. So now I'm going to try to get into my report. So currently, I have a niche private practice. I represent about a dozen community mental health boards, Upper and Lower Peninsula, all the way from Lenawee County to Scola, all the way up to the extreme western UP. I'm all over the place. Zoom allows me to do this. Most of the time, I'm sitting in my office in Plainwell, Michigan, shirt and tie on, and we won't go any further. In those roles, I see many aspects of how the mental health system has. So between what I'm seeing now, I grew up, if you will, in the Kalamazoo system, and I did not realize what a robust system we had in Kalamazoo. We had a state hospital there. I want to add there was another psychiatric hospital there for kids, Pheasant Ridge. When I started, we had kids in Kalamazoo too, and that all went away. When I see that and I layer that in with what I saw as an attorney referee and what I saw on probate, this big picture comes to mind about what's taking place as far as what the state's doing. I know you guys have been taking a lot of testimony, so what I'm hoping is to bolster that and not just be redundant on it. So, and I handed out or sent in a 4-page thing. I'm going to try to curtail some of that because I had to segue from what Ms. Huff said. So for expediency's purposes, I've really got 5 primary points today. My experiences across the state, Upper and Lower Peninsula, is getting folks into state inpatient beds. Difficult getting them into long-term inpatient beds, as Ms. Huff referenced. And then the hesitation once we finally get them in, and that's a process which is more than I can explain today, but trust me, that's a lot of what my niche practice is. I get a call from one of my CMHs that says, hey, we got this guy, he's in the jail, he's in the ED room, we need help getting into the hospital. Well, we have a process that we can help facilitate, if you will, and I'll put in air quotes, work with the department to get this, and it's challenge. The problem that happens with my CMHs is once we get somebody in, if they're in for 30 days, you're afraid to bring them out almost because, as we've already been testified today, I bring them out and they decompensate. Then guess where they go? The jail, the ED room, or whatever. So now you're impacting the criminal justice system and the hospital system, the healthcare system. So really what I think the bigger question is that we need to differentiate between acute community beds, like at your local hospital where somebody that needs to, I need to go in for 5 to 7 days. And maybe it's as much a substance abuse issue as it is a mental health issue. I just need to detox, get taken off, be brought back on my meds, maybe 5 to 7 days. What's really missing in the state of Michigan is these, I always say, not all hospital beds are made. The state psychiatric, sometimes it takes a long time, one, to ascertain what is and exact the diagnosis or diagnoses, and how do we do this. I also submit to you that, in my opinion, from all the jobs I've done, the state's shirking their constitutional statutory duty to provide the entire continuum of care. As was already been pointed out, we're either all the way here or all the way there. And we have nothing in the middle, and that's what creates some of this. The 4th point, and then I've got a few more comments on it, my position is, and I'm sure you all have heard of the Olmstead decision that came out in 1999. It was a big Georgia case. And truly, it needed to happen, this case, because we used to institutionalize everybody. The state of Michigan used to have about 20,000 people in their state hospitals. We used to have 16 to 17 state hospitals. When I started in 91, there was still a lot of them, and we slowly closed them and transitioned. The idea being you would transition out of those, backfill with these community supports or these specialized residential homes, and you could have this continuum of care. Also, when I started, we were a county department. The state was responsible. Under the mental health code, what they've done, all the state has done is delegated their duties. They haven't gotten rid of any constitutional obligation, any statutory obligation. All they've done is contracted with the CMHs. Part of a contract, anytime there's a contract, and basic law, I contract, You know, it's you make an offer, there's consideration given, and then you accept it, and then you fulfill the term. In my mind, the offer to the CMH system was, the system that we have built in the 80s and 90s, we're offering to you, local CMHs, you can have local control and you can control in your community. So what works in Alpena may not work in Kalamazoo, may not work in Traverse City. We're gonna give you the opportunity to develop what works best. Remember, we had 65% general fund, 35% Medicaid. So there was a lot more leeway. To me, if you take this basic law school thing, offer, consideration, acceptance, the consideration that us CMHs thought was out there was, the consideration from the state was, we will continue to supply this continuum of care to you. We will do our statutory constitutional duties and have this whole thing set out to where you can effectively manage within your community because we're gonna have this continuum of care. Well, my position is at a very second day of law school, they have shirked their duties on their consideration to us as far as our ability to do this. Another point that I've got in here is, and I think this is important when we're talking about this issue, the mental health code was written in 1974, and with very few revisions, has substantially stayed the same. So I want us to think about 1974. We had probably 5,000 to 6,000 people in state hospitals. We had 16 to 17 sprinkled throughout the state. Think about what was also different in, and I always say this when I talk to folks about this. In 1974, if somebody went into the psychiatric hospital and you had to do some of this stuff like a mental pickup order or orders, all you had to do was, you know, I would go, Dr. Pinter, I need you to go do a review on Steve and see if he's ready to be released. All he'd have to do is get up from here, walk down one flight of stairs because we were in the institution and talk about it. Everybody was there. Now the communities are so fluid. We're all over. We have computers. We have phones. It's not the same world, but yet the code was written for what our system existed for in 1974. And a lot of times I think the more you think about that, you realize we're trying to, if you will, the square peg into a round hole with what we're trying to do here. So getting a person in proactively in treatment before they hit the criminal justice system is impossible. I have a number of sheriffs that are friends of mine. We talk all the time, and what we're not doing on the CMH side impacts the criminal justice side, impacts the sheriff. You know, my sheriff, Richard Fuller, I think the world of him. We're different parties, but he and I have coffee frequently, and we have the exact same concern on all of this. And I submit to you that the inpatient bed crisis, and that's what we have, is not an acute bed, inpatient bed crisis, is a self-created one by the state, by them failing their part of the consideration on when we took over this, it was with the expectation that we were gonna have all the pieces. I've also used the analogy that the state gave us this 500-piece puzzle box and said, you could put it together any way you want. What we have learned is they kept out 3 pieces. So we'll never be able to, or 10 pieces, however many pieces you want to say, we can never put this puzzle together because we don't have all the pieces to do it. I think I beat that issue to death. So in my course of, and this is some of this stuff, I added this in, I indicated that clients will call me and we'll get somebody in the state hospital. When we're on the phone, and I'm not gonna name names, but I hear stuff from the State Department folks, hospital folks, and I think they're all well-meaning. I absolutely want to create or say that. They are doing their jobs as they've been instructed to, and they're allowed to. But I hear this all the time. Well, we don't have enough beds because we can't hire qualified folks. No qualified. Oh, we have intermittent FMLA questions. And these are all statements that have been said when I've been on meetings. And believe it or not, on a Zoom one time, I had a department person, as we went through this, turned to me and said, Mr. Burnham, we cannot take this kid because we can't handle him. There's nothing we can do. And my retort was, so my local CMH is supposed to be able to handle this? That's absolutely absurd, that statement. I'm sure he regretted it as soon as he said it. So I'm taking out anything I put at the children population. Ms. Huff covered that. Again, I say not all beds are made the same. I wouldn't say we necessarily need any more acute beds, say the 7 to 10 day beds. What we need is access to a longer length of stay treatment in the state hospital level of care, highly trained, fully staffed, specialized residential options. This is the gap that my clients are always talking about that needs to be filled. So what usually happens is the states always go, so while well-meaning, the department runs out new alphabet soups or word salad redundancies, PTRF, MyCare, MyCal, ICTS, MTCPA, behavioral health care provider, blah, 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 blah. They say all of this, it's all the same stuff dressed in the same dress, and they're still not providing the continuum of care. And that's why they keep cycling. If we get them into the hospital, then almost immediately we're being badgered to have these meetings on how do we get them out. And that's for another discussion if I'm allowed back in the building to talk more. Because that's a whole other process. But we try to keep them in so that we can do this. So collectively on any given time, and I have basically 12 CMHs that I work with a lot, my clients, on any given day, we're looking for 8 to 10 people that should be admitted to the state hospital for a longer length of stay that we can't. And we're constantly trying to serve them in the community. I kind of have a script when somebody calls me that they're looking. I always say this: tell me every rock you've turned over. Where have you looked at? What have you done to try to do this? And then my second question is always, when did this happen? I do not ever want to hear, when we get on a phone call or a Zoom with the state, I'll never allow one of my clients to say, well, 2 months ago we asked. We're always going to say, so today is Monday, July 1st. We are always going to be able to testify, well, at 12:55, June 30th, we called and they said, no, we are going to have the most up-to-date information. They are turning over every possible stone they have to try to accomplish this. And that's how, if you will, you have to fight the department. And I appreciate they have same issues. You're telling me my rural boards have qualified candidates knocking down their doors to come in and set up all this stuff? It's just not possible. And then, as I had said before, I suggest the department has a constitutional statutory duty to provide the full continuum of care, not just bits and pieces of it. I submit we've lost sight of what a local community mental health entity is really designed to do. And again, I reiterate, I started when we were next to the Parks Department, joint HSD CMH board, into becoming our own separate entity, into becoming part of a regional entity and all this. There's a whole continuum that's occurred there, and I feel like the CMH says, can we do better? Absolutely. But we need to have our partners, the state, help us be able to do that. You asked a little while ago how many beds. There's a report the Treatment Advocacy Center in 2024 released. And the number is kind of, and numbers are numbers, but this is one report, and I can get the report to the committee if they want it. And they did all 50 states. So per 1,000 residents, there should be roughly, according to them, about 30 psychiatric beds available. It's kind of unclear in the report on whether or not that's acute or state inpatient, but Michigan is about setting it around 18 beds per 100,000. So their report is for Michigan to come up to even get close to that 30, Michigan today would have to add about 1,000 beds across the state to be able to effectively manage this continuum of care. So if you want a number, that's a number I can give you, and I can get you the report, as to what that is. The Olmstead decision, basically it just said that we can't just throw people into an institution and throw away the key, just like we can't throw them in prison and throw away the key. But one of the biggest part of, and I state this all the time when I'm talking with the department, I feel like the state uses Olmstead saying, look, they said we can't institutionalize. That is not what Olmstead said. There's 3 main pieces, and this is in the report, the little paper I gave you all. States required to provide community-based services for folks with disabilities, but it applies to mental illness as well. When integration in the community is appropriate, the affected person does not oppose living in the community, and here's the key: the provision of services in the community would be a reasonable accommodation when balanced with available resources and other similarly situated individuals with disabilities. Nowhere in it does that say we must close all the hospitals. To me, this says the exact opposite. It says you have to build this continuum of care as far as what you're going to do. So we all agree that most people live with serious mental illnesses or developmental disabled can definitely live in the community. I think our CMH system has done amazing things. As I've been across, I see all kinds of incredible things that they've done and folks that we have living in the community as far as what we can do. And there's agreement that institutional placements are not conducive for achieving recovery and independence. But there should also be an awareness that the absence of a comprehensive community-based service and supports, including inpatient beds, long-term, for those who need them, can have horrendous consequences such as homelessness, incarceration, or high rates of suicide. I appreciate your time, your listening, you're not throwing me out. If you have any questions, I'd be happy to answer them.
Well, thank you. And I guess either of you could answer this question for me, but do you believe the current CMH system is working to provide the best possible care?
With what they're allowed to do.
Yes.
I'm an attorney, so you're not going to get a straight answer. So let me, I'll embellish on that. I think the CMH system has learned with the, if you will, the burden, and this is hard because I hear this all the time, and that's part of my question that I always say. When any of us testify, the department, advocacy groups, CMH directors, ask these second and third questions. So yes, I think they're being effective. But here's the thing, I ask all the time when I talk at CMH conferences, I ask a lot of times when I talk on liability and contracting. If I was to come to each CMH, and I've never asked Chris this, Mr. Pinter this, but if I was to come to you and say, look, we're gonna cut your budget by 25%, 25% right off the top, but I'm gonna flip it to where you have 50% general fund, 50% Medicaid. Would you take that deal? And I have yet to have a CMH director that wouldn't go, I think I could do that. Because I think they're very efficient in what they do, but we've turned them into an insurance company where unless it fits a code, you can't do it. It has nothing to do with what the clinician, the sports coordinator says we need to do. It's what does the code. We're driven by this, and we should be driven by that.
Mr. Chair, my answer is just a little different than the lawyers. I would say that as a system, if your community mental health center is accountable to your community and your constituents and your county commissions, then you probably do a better job in meeting your obligations. If you're distanced from them, if you don't take them into account in their feedback and the consumers and families, then you probably don't do as well. The reason I mention that is because in Bay County, they can have a special meeting tomorrow and they can end the authority, which means I'm out of a job. So my number one stakeholders are always the people in that county. And when people go to the county and complain that they can't get into my agency, I've got to do something because they just want the problem to go away. They'll make me go away if they can't get the problem to go away. So as long as those counties are actively involved in the mental health system, which is how it was set up in the law, then CMHs are reflective of those and they're reflective of their constituent needs. Now, do I think that sometimes gets distracted in some counties? Do some counties have other political things going on? Do they have so much money they don't know what to do with? Maybe. Never been my county. But I think it really comes down to how integrated your services are with your county commission and your other key stakeholders, education, the jail, the sheriff. And if you have good relationships with them, you're going to get good outcomes for the consumers.
I served on a county CMH board when I was a commissioner, so I'm familiar with that process, and I appreciate you guys being here today. Even in my time, which is, I have less experience than you do, sir, it has changed with the PIHP. They're supposed to be a collector and distributor of Medicaid dollars. I had a local board member recently who serves on the Mid-State Board tell me that they are now becoming a service provider as well. So they're dictating how much money you can receive for services and then stealing your employees, paying them more, and providing the service. Is that helpful?
And that was never the intent when they first set up the regional entities and then transitioned over to the PIHPs. And I just suggest to this on that, when I started with CMH, there was 46 contracts, Medicaid and general fund. The state managed that just fine. As we transitioned, and I was in Lansing a lot with Haveman and Jeff Patton and Pat Berry and Vicengardi and listening to all this, and we had meetings and you'd have discussions. You didn't always like what they said, but you could see a path to this. The idea was it was going to make us more efficient and allow us to serve better. And the whole concept of setting up the authority boards and all that was exactly what Mr. Pinner said. Your local CMH, if your local area says this is what we need, you pivot to that and you're able to do that. And when you had a lot of general fund, you could do that. Now everybody's the same. You have a lot of money. If you just look at the bottom line or the top line, you're just floating in money, but you can't spend it. That's never the intent. And I would submit to you that, and I know this isn't about the new supposed bid out of the PHPs and all that, because I have, as you may be surprised, some thoughts on that as well, but I won't share them today. We never really achieved what that was supposed to accomplish back in the 90s. And now we've gone along, so I mean, when I go and talk to boards, staff don't even realize they're governmental entities or they're part of the county, or as Mr. Pitcher said, 3 public hearings and boof, you're parked right next to buildings and grounds in the HR department, and you're going to county commission meetings.
I think, Mr. Chairman, I think on the PHP regional entity thing, I think it's important to see that as just a possible, that's a vehicle under the law that allows the county CMHs to function under a Medicaid managed care program. That was put in place we started working on it back in 96, 97, before the first capitated managed care contract. So whether the PHPs are reflective of their needs of their members depends on how strong their bylaws are written and whether their CMH members are exercising their governance authority over it. I've done well in our PHP. I was a stalwart PHP myself at Bay Aranac, but because I only had 30,000 covered lives, they shoved me into this other PHP with Saginaw and Midland, although that is our medical trading area, so I couldn't really complain too much, although Mary Ann knows that I did at the time. I think I've been in this PHP for 11 years, so for all the folks who hear about they're not spending their Medicaid, they must not need it. I overspent 9 of those 11 years. I've overspent my Medicaid. The region has enough scale that they were able to make us whole. Well, what have we overspent those services on? Well, the exact cases that Mary Ann mentioned. I spend money on kids that I can't get into a psychiatric hospital. I have kids that came up through the autism program that their single parents are raising them. Their house is tore up. You'll see drywall that's broken. You'll see the house in total disarray because they've kept this young man at home their whole lives. They do not want them to go someplace else. So we try to get home-based services in there. We try to do something to help those folks. That's where all my Medicaid goes. And as Steve was mentioning, I also have overspent my GF most of the time. Now, how have I been able to pull that off? Well, because we have some earn local that we're allowed under state law to earn some money and keep, and we use that money because I'm a nonprofit. I'm a governmental agency. I have to serve the most in need in my community, regardless of ability to pay. It's in the law. So when you guys hear the department say, well, those CMHs, they have a conflict of interest, I don't. I should have been fired 12 years ago because I overspend my budget every year. So where's my conflict of interest? My conflict of interest is I don't want the community to go to my board and say, fire that guy, we can't get services. That's my conflict of interest. It's not about money at all. But as we move further down this line of Medicaid, and Medicaid is basically a commercial healthcare system. It's predicated on a commercial healthcare system. As counties, we're finding more and more of this pressure that, well, you really are just like any other. No, I'm not like any other provider. What other provider will send his staff into the ER and the hospital to keep somebody safe out of pocket, money that he doesn't have, so that his board doesn't fire him? What other provider will serve the most in need at the point that they are the most in need, even when there's no state hospital beds to take them? Because I don't want the sheriff to come up with me in jail, which he did threaten a long time ago because of somebody up in Aranac County, but we have a good relationship now. So I do think Representative Green made a good point when she mentioned RFP. I can tell you the department has pushed us and pushed us and pushed us the last 4 years to be something that we're not. And when we have pushed back and said, well, under the law, really, it should be this. Really, under the law, it should be that. Well, we're just going to bitch out. We can just bitch out. We can get rid of you. So we can throw out 64 years of state law and precedents and get rid of you because you didn't do our bidding. Even though we can point in the law that we're exercising the flexibility and the discretion we have as governmental agencies, as sovereign entities, as counties, we can show that we're exercising our moral and ethical obligations under the code. And the state has an obligation then to support us and fund that, regardless of whether they like me or because I overspend my Medicaid or my GF. And that's the pressure on the system. And the inpatient bed, the acute bed issue with children just makes it worse. Because here I am, I did open a crisis residential program. I think I mentioned this last time. We redid one of our old group homes and turned it into a crisis residential to take off some of the demand for inpatient. I've got all these federal things going on that Representative McDonald mentioned that's weighing on all of us. That's going, even if slimmed down to something more reasonable in the open public debate forum, which it's more reasonable than it was in 2017. Trust me, you guys. I'm not saying it's wonderful, but it's more reasonable. We're still going to have to adjust to that. And adjusting to that change is going to require the state to make a lot of changes in the way they work with us in order to make it work. In the middle of that, I want to build more, I want to support more units for children and more services, children's respite, mobile crisis response for children. It's kind of hard to do that as a government agency when at the same time your primary funder is holding a gun and saying, we're just going to get rid of you anyway. So it's kind of hard for us to make those commitments, but we do it because our county, until we're gone, the people in the consumers and families in our community depend on us. So we have an obligation to them that pervades anything else we do.
Dr. Pinter, I'm glad you came back because that was good. And I know your county board and they love you, so they're not going to fire you.
Well,
They told me whatever I
Today,
do, don't cut you off.
as
and
Steve
give you
said,
much
today,
time.
as of July 1st at 12:55.
Yeah. Representative Green, I believe you had a question.
Well, and I don't want to pick a scab, but do you think there's a little bit of a conflict of interest having the CMH board members be appointed to the PIHE boards?
No, I don't, because we're not a commercial entity, we're a public entity. We're carrying out governmental functions that have been transferred from the state to the counties under the law. We're still responsive to local constituent processes. If somebody comes in and says, Chris, you only get the people in that you like, that you can make money from, I say then you go to my commission and have us voted out or replace us. Show up at my 6 public meetings a month or my 5 county meetings a month and say that you don't like this is not fair. You have constituent processes through democracy that you can make it. We're seeing it right now being fought out at the federal level. In 2017, they were going to block grant Medicaid. ACA was gone completely. Not just some people. It was gone completely. What stopped it? Enough pushback on certain people in the Senate, and they said, this is not good for my state. I can't do this. We're subject at the county level to those same dynamics. So to argue that we have a conflict of interest carrying out our governmental function would be the feds saying, we're not going to give the state Medicaid authority the Medicaid money anymore because you have a conflict of interest to keep your state hospitals open. We're going to give it to Blue Cross. And I'm sure if they do a good job, they'll look out for all 83 counties in Michigan. They won't be accountable to the legislature, but I'm sure they will do the right thing.
Okay.
So no, I really think that's overblown and overdone. But if I needed to get my board members off there and put some consumers on there in order to get people to shut up about that, I would do it.
Okay, so, one more question. We'll put that to bed. Would you agree that Michigan made a mistake by closing all the psychiatric facilities so quickly without a network in place to supplement all those closures?
It's been a long process. As Marianne said, there was a lot, and as Steve said, there was a lot more creative things we were able to do in the 80s when we had a different mix on state and federal funding. And then our managed care waiver in 97, that Governor Engler, who always played hardball with us, just so you know, and Jim Haveman, I mean, they put the managed care waivers in place to allow us the flexibility that Marianne mentioned to provide more services in lieu of state hospital. I think what the issue now for us is that we have some children we've identified through the ABA benefit who've came in for services, and I think we have enough situations where the cost-benefit analysis for the private hospitals is they don't want to admit the person because somebody can get hurt or they can cause damage to their facility, and to them it's not worth it. The problem is we still got to get them somewhere. And if we don't have a state hospital, we need to have other alternatives that we can develop and run.
So is that advocating for then state hospitals to be open?
I would say state hospitals are more county-based alternatives that we can use, that we can put people in secure settings.
Okay.
That would work too.
Gentlemen, thank you both. We're going to try to quickly move into our Zoom participants.
Thank you.
So our next presenter joining us on Zoom is Ann Runyon, Representative Child and Family Services of Northwestern Michigan. Thank you for being with us, and please begin when you are ready.
Good afternoon, representatives. I'm so appreciative of the opportunity to give you maybe a different perspective than you've had access to in the past. I am a licensed professional counselor. I specialize in adolescent development and animal-assisted intervention. I provided crisis intervention services in our regional crisis center for 10 years. That contract was ended in April 2019, and since then, I've provided mental health services to young people 12 to 20 in a variety of roles in the Grand Traverse region. I'm pretty focused on the severe shortage of psychiatric inpatient beds in northern Michigan. And I thought that it would be helpful to walk you through maybe the experience of an adolescent experiencing mental health crisis here in our region. I'm going to tell you about Laura. Laura is a composite of clients who I've worked with over just the last 5 years. Laura is 14 years old, and she has not necessarily been designated as severely emotionally impaired or even necessarily delayed in academics or in development. She's 14. She made the transition from middle school to high school this year, and she struggles with the increased academics, the increased expectations, and really intense social pressures. Laura's father works 2 jobs. Her mom works full-time and cares for Laura and her 2 younger siblings. And the family relies on Medicaid for health care and the free lunch programs at school. Laura is being severely bullied at school, but she doesn't tell anyone because her parents already have too much going on. She's emotionally stable for the most part, or has been until this year, when her stability has deteriorated rapidly. And that's resulting in increasingly restrictive punishment at home and at school, just because that's what folks know to do. Laura had a particularly difficult day at school and then finds out that her mom got a call from school and she's got 10 assignments missing out of her 8 courses. Her already exhausted parents decide that the problem is how much time she spends on her phone. They take away her phone, tell her she can have it back when she accomplishes all 10 assignments. Unfortunately, as an adolescent, the phone is Laura's primary way of keeping in touch with supportive friends. And without her phone, she's effectively cut off from the supportive relationships she relies on. So her anxiety increases. Her voice gets louder, speech gets vulgar. And as she talks, she starts talking about killing herself. Nothing her parents say helps her calm down. And reacting to their own fear, they resort to threats of further punishment to get her to change her mind. Laura's distress escalates. She picks up a razor from the bathroom, slams the door to her room. Her parents go to the door, open it, and Laura's not having it. She's not going to do anything differently. She is now in fight or flight mode. She's not thinking clearly, doesn't have access to logic and reason. Laura's parents called 988 for help, but the only recommendation that the crisis interventionist on the line can give is that they take Laura to the emergency room. They suggest calling the police if they need help getting her in the car. Obviously, 14-year-old Laura is not going to get in the car voluntarily most of the time. When the police arrive, they scold Laura for being a bad kid and insinuate that they'll take her to jail if she doesn't get in the car. So Laura ends up in the ER. When she gets there, she's greeted by staff with little or no training, overworked staff, little or no training in managing mental health crisis. The hospital has some funding for mental health care specialists. However, they can't employ those people after hours. And there is no longer a mobile crisis intervention service to come and evaluate Laura. So she's admitted to an observation room in the ER. She's required to have one-on-one supervision. And that one-on-one supervision has to be provided by a parent unless there is a hospital employee who can do so. Staffing challenges the facility, questions of facility. Laura has to be admitted to an observation room. So that is a room that is no longer available to anyone else, any other patients in the hospital. And she's going to spend anywhere from 24 hours to, I believe the record for clients that I know is 23 days in the emergency room waiting for a bed in one of the facilities that's already been mentioned. The closest bed is going to be 2.5 hours away. Her parents are likely to be required to transport her unless she requires ambulance transportation. Either way, parents have to drive 2.5 hours to whichever facility to make make her admission happen. They have to drive back to get to work on time. And so they have to leave 14-year-old Laura at this strange facility with these strange people, having already been labeled as a difficult child. The ideal treatment length for Laura would be about 21 days. Staffing and demand for beds going to shorten that to about 5 to 10 days. Because of the distance, Laura's family won't be able to participate in any of the vital support meetings, family support meetings, family groups that often offer parents the opportunity to talk to their peers. They'll only be able to drive it down again when Laura's released back to their home. And although they will have been given recommendations for referrals for ongoing care, mental health providers who can afford to take Medicare reimbursement have high requirements for eligibility and long wait lists. Without appropriate treatment, skills training, and support for her parents, and lack of access to ongoing care, it's likely that Laura and her family will repeat this taxing process up to 3 times in the next 12 months. Unfortunately, hundreds of people, adolescents, children, and adults end up trapped in this cycle every year. I'm sure that I don't need to explain how different their outcomes would be with access to local inpatient psychiatric care, not to mention the benefits of the attendant aftercare. More beds doesn't just mean more beds. Along with those beds come the opportunity to hold parents groups, the opportunity to provide group or ongoing outpatient care for Laura and her peers. The increase in beds means an increase in mental health staff at the hospital or at the facility. It means there are innovative people being creative closer to where Laura lives, closer than 2.5 hours. There are opportunities for funding for her parents to be able to either take time off work or be able to receive a gas card to travel to a more local facility to participate both in her care and get the care that they need to be able to provide care for Laura. The benefits of the attendant aftercare and follow-up then benefit the community as a whole, rather than ending up in this cycle, ending up with a diagnosis of a mental illness. Laura has the opportunity to spend the time that she needs in care in the appropriate psychiatric facility. Her family, her parents receive the support that they need to continue her recovery at home with appropriate care. And Laura has one 21-day stay in a psychiatric facility. Family gets the support that they need, and she doesn't have to go back. I'm not a politician and I'm not a policymaker. What I can tell you is that I have walked with Laura through all 4 hospitalizations in a year. And not one time has she or her family received the skill building and support that they need to make sure she doesn't have to go back. That's what I have for you.
Turn that down before. Thank you very much for that, Ann. I think it's been made obvious through not just your testimony, but from other testimony we've seen. Not only is that adolescent bed space missing, but Northern Michigan has truly been neglected in this process over the years. I don't see any questions from the committee for you. Thank you very much for your time and for your testimony. We're going to go to our next Zoom participant. Sarah Bush is a case manager and social worker with the Grand Traverse County Sheriff's Department. Sarah, thank you for being here, and I hate to say this to you, but I need you to keep it brief. We have one more person who I promised 5 minutes at the end of our committee. Oh, and we can't hear you.
You hear me now?
Yes.
I said I will keep it brief and I will only present the facts. Thank you for giving me the opportunity to share regarding the ongoing mental health crisis in our community. I work for the Sheriff's Department. I do jail diversion. The sheriff just started this program in January. We experience a psychiatric crisis and are unable to access appropriate care in a timely manner for people who are incarcerated. We currently have 169 individuals that are incarcerated in our facility right now. And out of the 169, we have 38 cases that are diagnosed as severely and persistently mentally ill. 85 of them have co-occurring diagnosis with substance use and mental health, and 40 of them are just strictly substance use. Since January, our jail has done 12 petitions, with only 7 of those petitions being placed inpatient hospitalizations, with 5 of them being classified as high acuity because of their jail hold or because of resisting an arrest with an officer. The lack of bed space for the high acuity beds is very challenging, especially on our department. We have to provide an officer to sit with them at the hospital until they find a bed. And if they can't find a bed, then after 10 days, we have to bring them back to our facility and re-petition. And then we go through this process again. Let's see, sorry. Since January, this has generated over 197 hours of overtime. And also our officers will have to transport these high acuity jail holds to the facilities. Typically, the 2 facilities that have accepted those people have been downstate. So they're making a 4-hour trip down to Detroit and back. And then they have to pick them up as well. In our Traverse City Munson psychiatric unit, we currently have 14 beds open, and our high acuity part of those beds is closed. Northern Lakes Community Mental Health just laid off 35 people this week. As the Sheriff's Department, obviously this affects public safety because it affects our shift strength and what we're able to provide to the community. And we did start the jail diversion program where we are educating our officers to utilize mental health services and petitions we educated them on. And so that's been working a little, but the bed placement is really where we're struggling. Currently, right now, I have 2 people that are in Munson with 2 officers that are sitting with them for the last week because we can't find a bed placement. I won't touch on the juvenile stuff just because I know everybody touched on that. I urge you to increase the number of beds in Northern Michigan because I do feel like it's been neglected. Prior to coming to the Sheriff's Department, I worked for CMH, and it's really hard to see these people over and over again come through the system. And once they get in the court system over something that should have been addressed and as a mental health and not necessarily arrest, it's hard for them to get out. It's just a repeating cycle, and it's a vicious cycle. Not only is this just a healthcare issue, but it is a public safety issue. And without action, this gap in our community is going to continue to grow. I'm open to any questions that you guys have. I know I have a short amount of time. I thank you for your leadership and prioritizing the beds in Northern Michigan. And if you have any questions, let me know.
Thank you, and I'll try to keep it brief, just from my standpoint. So those folks that come into the jail that need mental health services, and they're probably in jail because of their mental health condition, because of the constraints of them being in a secure facility, are they receiving the optimal care that they should get for the mental health conditions they have?
No, they are not. Not to mention, if for some reason they are ordered a forensic evaluation, our forensic right now is booking out 5 to 6 months. So I have people with significant mental health issues waiting to go to the forensic center, and they're waiting 5 months. And then they do it either via Zoom, and if they say they need a second opinion in person, then we have to wait another few months for them to get transferred down for that. That's also another lag and thing that we are struggling with.
And this is more rhetorical. It's not free to stay in jail, correct?
I'm sorry, what?
It's not free to stay in jail.
It is
Costs
not free.
somebody, the state, the county. So we could be spending these money on services and get
Correct.
people the help they need. Are there any further
Correct. questions
from the committee? Thank you very much for your time. Greatly appreciate it. Again, thank you.
No problem. Thank you.
Next up, wishing to testify is Jim Casha. Jim, he's been put a card in a couple of times, and so we reserved some time for you. Please push the red button when you're ready to speak, and you have about 6 minutes. I believe.
Okay. Well, I do appreciate the time. I don't know how I'll be able to accomplish this in 6 minutes. Joe can testify that I've been here for 19 years on this issue. My involvement with this goes back over 50 years ago when the state, and I know this is going to sound crude, but this is what they did, dumped 2 Michigan foster children in my parents' home, right from the hospitals where they were born, in 1971, and then 4 years later, they begged her to take another one, which her only reply was, "Bring him." They dumped him. Now, my mother doesn't have any fancy letters after her name or before her name. But the one boy she was able to ascertain had a medical issue, even though he was in intensive care for 3 months. And we took him back to the hospital the next day where he was diagnosed with a hernia. When these boys grew up, my mother told the state, "There's something wrong with these kids." Okay. We went to psychiatrists and psychologists with the one boy, and this is the early 70s, and the kid walked out of the office and down the road. The psychiatrist said she had never seen anything like this before. The reason is they were beginning to see the second generation of kids born after World War II to prenatal alcohol exposure. These were the babies born from baby boomers prenatally exposed to alcohol. These were their children, all right? And back then, nobody had seen it. But 50 years ago, a doctor diagnosed the first foster child in Michigan with fetal alcohol syndrome. This was the forefront. Dr. Kenneth Lyon Jones was part of the team. So there may have been an excuse for not knowing about it back then, but there's no excuse for not understanding the link that alcohol plays in this role for need for more psychiatric beds. And if you don't address it, it's only going to get worse. It's a, to paraphrase Governor Jimmy Carter in his 1974 speech at Law Day speech to Georgia University to a bunch of distinguished law people, that he's not qualified to talk to them on the law, because in addition to being a peanut farmer, he was an engineer and a nuclear physicist. Well, I'm not a medical doctor, okay? I am equine massage therapist, a horse massage therapist, an Amish auto mechanic, and an engineer, okay? And we solve problems differently, all right? This problem needs to be solved backwards, in the reverse. Find out what exactly happened here to cause all these children that we hear everybody testifying about, all right? We lost everything. The first baby boomers that were born prenatally alcohol exposure had two-parent homes. Their children did not. Their children had bad parents. They were bad parents. Their parents were bad. Their grandparents were bad. It's an impossible situation. The first time I met you was on June the 3rd. I sat in 3 committee meetings, all related to the same thing. Your committee had both the alcohol board here and and the need for more psychiatric beds. I'm falling out of my chair. And Joe can testify, when he was a representative sitting in one of these rooms, along with another representative from who was a lawyer from the city of Detroit, and his father was a judge, and listening to the Jennifer Granholm's deputy director of the Michigan Department of Community Health, or Corrections, tell the special committee on recidivism that the best way to reduce recidivism was proper prenatal care, which I fell out of the chair, probably that chair, or one similar, all right? Because that's what I came to tell them. So we know the link, and we know the link to mass school shootings, proper prenatal alcohol exposure. And we're concerned about the escalation of violence against politicians. There's an addendum in here that talks about Lee Harvey Oswald. We have a health secretary, Robert F. Kennedy Jr., whose family was at the forefront of this issue. Eunice Kennedy Shriver, the department and the NIH is named after her. They were the forefront on this. There's no excuse for this legislative branch not to address this issue now. Now, you have to do it, all right? You have to do it. Wayne Church counseled suspected gunman, pastor says, as police release his identity. What's his story, all right? They forgave him on Sunday. He doesn't need forgiveness. He needed an apology, all right? And what's his mother's story? Why don't we find these things out? I know this may not sound pertinent to you, but as an equine massage therapist and an engineer, I approach problems, like I said, in a different way. So when I have a whole family of horses all showing the same genetic signs of lameness, and one gets killed through a lightning bolt, I autopsy it and I find out what the problem is. That knowledge can then be applied to hundreds and hundreds of others. We need to do the same to the children. We have the facilities here in Michigan. No state in the union is better prepared to address this with the diagnostics, research facilities. Much of this research was done at Wayne State University. We had the NIH's perinatology research branch at the Detroit Medical Center for decades until it got underfunded by the legislatures. You got to give me more time.
I have
Not
to
today,
adjourn.
but you got to give me more time.
Let's talk.
You
But
got to give
I
me
have
more
to
time.
adjourn.
You got to
Thank you.
talk to me. I'm not going to go away. All right.
No
I'm not
problem.
going away.
There being no further business before the committee will stand adjourned.